Good afternoon, everybody. At the outset, I will like to thank the organizers and Professor Chandra Kumar sir, who is sitting in front of me, for giving me this opportunity to present my talk in front of this very prestigious and august gathering. I have been allotted a talk, Anesthesia for Cataract Surgery. This is the place where I work, Rajendra Prasad Eye Center, All India Institute of Medical Sciences, Delhi. It is tertiary care center and it is a premier teaching institute. We do around 12,000 cases under general anesthetics, and which includes around 200 to 250 cases of neonatal and infantile anesthesia coming for retinopathy of prematurity. No conflict of interest. I will be covering all these topics during my presentation, from demography to controversies. So, what is the pediatric cataract epidemiology? It is a major preventable cause of a childhood visual impairment and blindness in the world. Blindness prevalence is 1 to 4 per 10,000 children in developed world, while 5 to 15 per 10,000 children in developing world. So the load in the developing world is much higher than that of a developed world. This congenital cataract is associated with ocular abnormalities in 27% cases, systemic abnormalities in 22% cases. Diagnosis of cataract is incidentally made on routine screening in 41% cases. There is no difference in prevalence based on gender or laterality. I don't know how it is moving. So congenital cataracts, etiology-wise, most of them are idiopathic. Very rarely they are because of prematurity. Infections like German measles, herpes simplex, CMV, Treponema pallidum, rare metabolic diseases like galactosemia, Fabry's disease, non-metabolic syndromes, Hallermann-Streiff, Marfan, Alport, and so many others. Right. Acquired cataract, mainly it is caused because of a trauma or diabetes or other metabolic disorders. And certain systemic disorders like asthma, leukemia, Crohn's disease, and arthritis. Surgical treatment indications, any cataract which is visually significant more than 3 millimeters central opacity, obscuring posterior pole with strabismus or nystagmus, should undergo a cataract surgery. When it is earlier is the best. Higher incidence of glaucoma, 4 to 6 weeks and 6 to 8 weeks is the period. If unilateral cataract should be operated early, 4 to 6 weeks of period, and bilateral cataract should be operated at between 6 to 8 weeks of period. Operating them earlier, 4 weeks will, there is a higher incidence of aphakic glaucoma. Operating them after 6 weeks, there is vision disturbances. So this is the ideal period. And all cataracts should be operated prior to the 12 weeks, unilaterals earlier than the bilaterals. Pre-anesthetic assessment, that depends whether baby is presenting with the cataract as isolated disease or presenting with the cataract with comorbid conditions and syndromic condition. So if baby is with some associated conditions and syndromic condition, they should be investigated thoroughly to find out what is the cause of a cataract. Right. And in these cases, you have to evaluate associated comorbid conditions and syndromic condition in terms of severity, manifestation, and you will have to involve the specialist according to the involvement of a system. Cardiovascular system, cardiology, neurology system, neurologist. Accordingly, you will have to involve the specialist for diagnosis, optimization of a baby prior to the surgery. And one of the most important is if it is syndromic child and if you suspect, you have to be suspicious about a difficult airway in this patient, so you should look at it while during your preoperative assessment. This is one of the study published by Japanese article which says that where they have 10-year experience at tertiary care hospital regarding management of the cataract patients, and they said the development of systemic complications following pediatric ophthalmic surgery is rare. So preoperative tests should be asked with the caution. They should ask only when they are required. So it is very low risk surgery. And this is some statistical data from one of the hospitals where there 700 patients were operated. Out of that, 400 patients didn't have any disease. They are ASA1. Allergic condition 108, asthma 74, developmental disability 51, neurologic disease 37, congenital heart disease 33. Out of that, congenital heart disease is a lot of a concern. So most of the babies don't have any issue, and they can be anesthetized very easily without any problem. So investigation, routine, if baby doesn't have any associated disease or problem, only hemoglobin can be done. That too in our country because children are anemic many times. And so you have to evaluate them for the anemia. Otherwise, other investigations will depend upon what comorbid condition or syndromic association patient is having. Now, perioperative anxiety is one of the very important issue because it is associated with adverse clinical outcomes like emergence delirium, increased analgesic requirement, negative postoperative behavioral changes. We will be discussing the ways to allay this anxiety. While infants less than 9 months will readily accept parental surrogates and are less likely to experience anxiety on the separation from the parents. They may not require pre-medication. So pre-induction techniques to manage anxiety can be classified as a pharmacological and non-pharmacological. Pharmacological are sedative premedication, opioids, hypnotics. Non-pharmacological, we'll discuss after the pharmacological one. Commonest drugs used are benzodiazepines. Out of that, midazolam is very common, alpha agonist, clonidine, and dexmedetomidine. Out of that, dexmedetomidine has become very popular in recent time. A lot of my colleagues this keep on moving. That keeps on moving. And this slide is also keeping on moving. Can I have this?
Can we have this microphone?
Midazolam is most commonly used drug. It has got benefits that anesthetist has got familiarity to use. Okay. Anesthetist has got familiarity to use this drug. It has got quick onset, brief duration of action. It is effective preoperative anxiolytic, may cause androgen amnesia, reduces postoperative nausea, vomiting. However, these amnesic effects may result in children displaying more anxious behavior. Dexmedetomidine is highly selective alpha-2 adrenoreceptor agonist. It produces, apart from anxiolysis and sedation, analgesic effect and avoidance of respiratory depression. And its sedation resembles a natural sleep, but one of the meta-analysis shows that the sedative effect produced by dexmedetomidine is not superior to midazolam, and it has got disadvantage of producing bradycardia and hypotension. Non-pharmacological behavior consists of behavioral interventions and presence of parents during induction of anesthesia. Behavioral interventions like play therapy using visual aids like videos, interactive books, dolls are useful. Use of music videos on mobiles. This is most commonly used technique to lure the child while taking him inside the theater or when the child is in a recovery room. And distraction methods like blowing up ties or engagement with the anesthetic process itself, using handling of the face mask, blowing up the balloon, can be used in the young children. This is most commonest technology of behavioral intervention used in the clinical practice. This is a pre-anesthetic room of our hospital where the babies are usually with their parents, with the very friendly surrounding. And This PPI, what I was talking about, it has got very variable evidence in the literature. According to this systemic meta-analysis and research, PPI reduces parental and patient anxiety, may increase parental satisfaction, may not impede operating room efficiency, and it should be considered as a valuable tool to improve surgical outcomes. While this is Cochrane review, which says PPI did not diminish anxiety, behavioral interventions are more useful than PPI, and combiningly PPI and behavioral interventions do not provide any superior anxiolysis to the use of sedative premedication. Sedative premedication produces better anxiolysis. But in our setup, which is a very busy setup, where pre-medicating child, every child may not be possible because turnover and the sequence of patient being changing all the time. These techniques are of immense importance in our setup. Like I'm trying to show you this. This is a separation of presence of parent during induction. So this baby is nicely with his parent. And see, she is quite comfortable, cool, quiet. She is not very terrified about what is going to happen. The father has taken her to that theater table. He's sitting on the table and baby is likely to be induced in his lap. So the PPI helps many times in this kind of children. And these are those babies being made busy with playing with the anesthetic bag, of blowing the balloons and all that, blowing the anesthetic bag. So, and this is another example where this baby is not accompanied by her parents. This baby is taken away by the anesthetist. The baby is not willing to come to the anesthetist. And she has been taking her to the operation theater. And look at it, the baby has been so distressed, crying all the time. And this is not what we want for this video I have made just for the demonstration purpose. This is not our clinical practice. Okay. And then we come to the anesthetics techniques, balanced anesthesia technique with either inhalation, induction, or IV induction. Use of muscle relaxant, we use short-acting muscle relaxant like atracurium. We use a 50% dose of atracurium. There is not much scientific evidence of using it, except one publication in Saudi Arabian Journal. But in our clinical practice, we find it very effective and useful and associated with quite a rapid recovery. The use of nitrous oxide is associated with increased incidence of PONV. So myself personally do not use nitrous oxide. Many of my colleagues use it for faster induction. Now, inhalation and IV induction techniques, situation where you can use. Inhalation technique may be preferred because most of the children are needle phobic, or in children with a difficult IV access, or children with a difficult airway where you can titrate the inhalation agent so that baby doesn't go into the obstruction. Age-wise consideration of IV and inhalations. Infants have no apprehension for the impending procedure and amenable to inhalation induction. Children 1 to 3 years old resist to any method of induction, and their small veins are not easy to cannulate, so inhalation induction may be appropriate. The older child may be encouraged to choose between inhalation and IV methods for induction. So inhalation induction may be of more choice as compared to the IV induction unless until IV induction is faster, rapid recovery, and less irritating. Safer in children with irritable airway like upper respiratory tract infection, as the incidence of respiratory complication, laryngospasm, bronchospasm are less with IV induction. Appropriate if venous cannula already in situ, and preferred technique if there is a risk of aspiration. Anesthetic consideration, aim for motionless eye either with deep anesthesia or muscle relaxant. With muscle relaxant, rolling of eyeball may not be observed, it is less. If you are using deep anesthetic technique, if the rolling of eyeball happens, you have to deepen the level of anesthesia with some propofol, and it helps most of the time. Avoid high IOP with smooth induction and emergence. Consider controlled ventilation to avoid hypercapnia. give antiemetics to the patient. Now, another issue is whether laryngeal mask airway or endotracheal tube intubation. Uh, Laryngeal mask airway had been with us for another more than 2 decades, and it has become a standard of care for management of children coming for pediatric anesthesia. I can recall the period when I was junior faculty, and at that time there were no LMAs, and we used to use endotracheal tubes for all the children, all the patients, right? It used to be extremely time consuming. Many times one or two kids used to get difficult intubation. There was, more time being wasted in induction. Surgeons used to get very disturbed about it. And then there was very high incidence of laryngospasm, bronchospasm, endobronchial intubation, other issues. But with the advent of LMA, all these incidences of bronchospasm, laryngospasms have gone down remarkably well. So in my opinion, pediatric ophthalmic anesthesia is a subspecialty which has been immensely benefited by the invention of LMA. Apart from that, it maintains better hemodynamic, less interference with IOP, and less respiratory complication. Another issue we come across in cataract surgery, patient may come with the upper respiratory tract infection. Like there is a classical teaching that if there is a respiratory tract infection, postpone the patient for 2 weeks. But it should be decided on the patient-to-patient basis. If patient is having mild, you are running up nose, when the chest is clear, mild cough is there, you can accept the patient for the surgery. Cataract surgery is also time-bound surgery and should be done. Unless and until patient has got cough with expectoration, with chest is having crepes and all that, then patient should be referred to the pediatrician to antibiotic therapy and other medications, and then should be taken as soon as possible. And use of laryngeal mask airway had been very useful in management of URO patient. There is enough scientific evidence that incidence of respiratory complications are less when you use laryngeal mask airway. Then another issue associated with cataract patients is syndromic children. Okay. So syndromes can be associated with various issues. These are the syndromes associated with cardiac defects. Marfan syndrome, which is associated with aortic valve issues, aortic valve regurgitation, mitral valve regurgitation, or dissection of or impending development of aortic aneurysm. You have to take into consideration all these issues prior to anesthetize the patient and preparation of patient. Down syndrome is one of the commonest syndrome coming for the surgery, and they have got to use the ASDs and VSDs. Then trisomy 13, 18, these are very rare. Rubella is another common syndrome which is coming for the surgery here, which is associated with the triad of PAD, PDA, VSD, cataract, and deafness, sensory neural deafness, right? And certain patients can have syndromes are associated with central nervous system impairment, Conradi syndrome, Lowe syndrome, and this accurate neurological examination should be done, diagnostic and instrumental tests advisable to rule out the complications, and there can be possibility of electrolyte impairment due to pre-existent therapy. Renal impairment can be associated with Alpert and Lowe syndrome, and craniofacial can be with Hallerman, Streiff, and other syndrome. In all these pathologies, difficult intubation has to be considered, and fiber optic bronchoscopy has to be ready in hand in the operating theater. Managing difficult airway, you should have effective preparation, adequate expertise in the management of difficult airway, adequate knowledge of whether difficult airway algorithms, and you should have appropriate equipments to manage the difficult airway. So this is one of the videos I'm trying to show you of Hurler. This is, sorry, not playing. How do you play it? It's not playing. Okay. Okay, I'm sorry. I'm not able to play it. Is there any way you can play it?
Can somebody help? So there, this is the next slide.
Yeah. Okay. 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 Okay, this video. This is a patient with the golden heart syndrome with difficult airway, who has got a cleft lip and cleft palate. So this is being managed with use of a CMAC blade, and we are intubating the patient for further management of the anesthesia. Uh, Rarely there is a congenital cataracts in premature infants are also seen. Timing for surgery is 44 to 46 weeks of post-conceptional age, and we should be careful with optimizing their hemoglobin and looking after them for 24 hours in high dependency unit. I will leave this. This is one of the cases with bundle branch block and AV block who had come for the cataract. During initial exposure to the anesthesia, patient had severe bradycardia. So patient was referred to the cardiologist, and he was advised, he was diagnosed as RBVV plus first degree block. And so second time we anesthetized the patient with propofol IV induction and maintained with air, oxygen, and sevoflurane. Intra-op, he had some bradycardia, and for otherwise, the patient has received some isoprenoline infusion. So that's it. This is the topic which will be covered by other people with Down syndrome, Marfan syndrome, and just I'm showing you the pictures, right?
Give us your summary, please.
Okay. So to summarize, cataract surgery is second commonest surgery in the pediatric ophthalmic surgery, very commonly done. Most of the patients do not have any medical issues. They can be done easily without very basic preoperative assessment and management. Their ideal period, I have already told. If they are associated with syndrome, according to the syndrome, management has to be done. It is very low risk surgery, and even if patient is having very complex systemic issue, the surgery can be performed in them. And there is no need to postpone the surgery. With that, I will end my talk. Sorry for taking a longer time. Thank you very much for your attention.